Hi everybody, and welcome to our module on pulmonary function tests. So to put pulmonary function testing into context, let's talk about dyspnea. So when patients come to physicians and complain of shortness of breath, there are many causes. And in actual practice, one of the most common is deconditioning. Patients who are out of shape or overweight will often develop shortness of breath when they exert themselves. Then, of course, there are cardiac causes like heart failure and coronary disease. You can get dyspnea if you are anemic. But then finally, there are the pulmonary causes. And this is often what many people think about because since we're short of breath, they assume it must be a lung cause, but not necessarily so. There are many other causes. So we can split the causes of pulmonary dyspnea into two categories. The first category is obstruction and the second is restriction. So in obstruction, there is a problem getting air out of the lungs. Air gets trapped and can't get out, and therefore you have poor ventilation, and that leads to poor oxygenation. In restrictive lung problems, you can't get air into the lungs, and this results in poor ventilation and poor oxygenation. Another way to look at this is to think about a little alveoli, which is a little air sac here connected to a bronchus. So in obstruction, the problem is generally here. This bronchi is narrowed, and the air cannot get out of the air sac of the lungs, and therefore there's poor ventilation. In restriction, the problem is that the alveoli cannot inflate fully, so it inflates partially or maybe not at all, and therefore you don't draw air in, and when you go to exhale, there's less air to push back out. So pulmonary function testing is a method to determine the patient's airflow and the volumes in the lung. And it's a type of testing we use to determine the cause of dyspnea. Specifically, it helps us figure out if there's obstructive or restrictive disease. Now, we don't always do pulmonary function testing. Sometimes it's clear after the history or the physical exam or the x-ray what the problem is. But if it remains unclear, PFTs can help you figure out what the cause is. In addition to telling us why someone is short of breath, pulmonary function testing helps us monitor disease severity and progression. There are many diseases that are monitored by serial pulmonary function tests. For example, COPD and pulmonary fibrosis. In both of these conditions, patients have routine PFTs to determine whether their disease is progressing or improving or staying stable. The way we perform pulmonary function testing is with spirometry, and that requires the patient to blow into a machine called a spirometer, and this is a picture of it down here. The patient usually takes in a breath through the machine and then blows out as hard as they can, and the volume of air is measured over time, and from the change in volume of air over time, we can determine a lot of things about the lungs' health and function. So this is an example of the data that you get out of spirometry. So down here on the x-axis is time. So time is marching on as we move this way. And on the y-axis is the volume of air that the patient has blown out. And you can see that they blow out most of their air in the first second or so, and then they blow out less as time goes on, and eventually it plateaus out at a point up here. And there are two important measurements we can make from a simple spirometry measurement like this. The first is called the FEV1. That's the forced expiratory volume in 1 second. So we look down here at 1 second and we see how much volume of air they blew out in that first second, and that's called the FEV1. The second measurement we take is called the FVC. That's the forced vital capacity, and that's the total amount of air that they were able to exhale after a maximum inspiration, and it's where this line plateaus up over here. So we can get the volume FVC from a spirometry measurement as well. And a normal FVC is about 5 liters, and a normal FEV1 is about 4 liters, so therefore the normal ratio of FEV1 to FVC is about 0.8, and this will be important later when we talk about lung diseases. So the data you get from a spirometry test is called a spirogram, and there are 3 spirograms on this picture here, one from a normal patient in blue at the top, one from a patient with restrictive disease in green, and one from a patient with obstructive disease in red. And you can see that they all look different, and you need to know how to recognize the different shapes. So let me give you some hints to help you with that. Patients with restrictive disease have a normal slope and shape to the spirogram curve. They don't really have a problem with the mechanics of getting the air out. It's just that they couldn't draw in enough air in the beginning, therefore they pushed less air out. And so you can see that the total volume of air pushed out by the restrictive patient is much lower than the total volume of air pushed out by the normal patient. But the shape of the spirogram remains the same. In obstructive disease, the shape of the spirogram changes significantly. The slope is much slower in patients with obstructive disease, and that's because there is an obstruction. It's harder for that air to get out. It can't go out rapidly like the normal or the restrictive patient because it's blocked by obstruction, so it goes out slowly. And if you can remember that the slope of the curve is different in obstructive compared to restrictive, it's very easy to recognize these curves. There are many different ways they can show you the spirogram data, but in all of those cases, the restrictive patient will have a similar shape to the normal patient, just smaller volumes, whereas the obstructive patient will have a much different slope and shape compared to normal. So let's look at some of those volume measurements we make from the spirogram and see how they change in restrictive and obstructive disease. So here's the FEV1 for the normal patient way up here. And you can see that for the restrictive patient, the FEV1 has fallen. And that should make sense to you. This patient has a restriction and they cannot draw in as much air as normal, so therefore they don't have as much air in their lungs to push out. The volume of air that goes out in the first second is lower. But you can see that the patient with obstructive disease has a much lower FEV1. It's way down here. And that's because they have an obstruction to outflow. It is very difficult to get that air out. So it's important that you understand that both restrictive and obstructive diseases have a lower FEV1 than normal, but the decrease in FEV1 is far greater for patients with obstructive disease. Now let's look at the FVC. So it's way up here in the normal patient, and it falls for both patients with restrictive and obstructive disease, although it falls for different reasons. In the restrictive patient, it falls because they can't draw as much air into their lungs. In obstructive disease, it falls because they can't get as much air out of their lungs. And you'll notice that the degree of decrease in FVC is relatively similar for the two diseases. So they fall by roughly a similar amount compared to the FEV1, where they fall by very different amounts. So to summarize, the FEV1 and FVC fall in both obstructive and restrictive diseases, but the FEV1 falls more than the FVC in obstructive. So let's look at this table down here. In obstructive disease, the FEV1 falls a lot, and the restrictive patient has the FEV1 fall somewhat. The FVC drops somewhat in both diseases, and this is going to have a major impact on the ratio, and that's where this ratio is really important for separating obstructive from restrictive diseases. In obstructive patients, the ratio of FEV1 to FVC is going to fall. In patients who have restrictive disease, it's going to be normal, or it may even rise. Remember, 80% is normal, so it may be equal to or greater than normal, and that's because of the differential changes of FEV1 and FVC in most diseases. This table right here is very high yield for all three steps and even internal medicine boards, so make sure you know it. Now let's talk about all the volumes in the lung and what we can measure with spirometry. So let's look at this picture over here on the right. This is a picture that I go through in more detail in other modules, but for our purposes here, let's look at this red line here. And notice that it goes between 2,500 and 3,000 cc's, sort of up and down, as the patient is taking normal breaths. And that amount of air that goes in and out with the normal breath is called the tidal volume. If the patient inhales as much air as possible, the volume goes all the way up to almost 6 liters. And this extra amount of volume that they're able to inhale beyond the tidal volume is called the inspiratory reserve volume. If the patient blows out as hard as they can and tries to empty their lungs as much as possible, the volume will go way down here, down to almost 1 liter. And that extra amount they're able to push out is called the expiratory reserve volume. Now you'll notice that there's this little bit of air down at the bottom called the residual volume that you can never get out. No matter how hard you exhale, you can never get that residual volume out of your lungs. Some other volumes that are important are the vital capacity right here. That's how much air you can blow out after a maximum inspiration. So if you inspire all the way up here to 6 liters, blow out absolutely as hard as you can. The difference between those 2 points is the vital capacity. So spirometry can measure the vital capacity. In fact, that's what you do, is take in a very deep breath and blow out as hard as you can. So all that air you blow out is the vital capacity, or the FVC. It can also measure the inspiratory reserve volume and the expiratory reserve volume, and it can also measure the tidal volume. However, you should know that spirometry cannot measure the residual volume, and that means that it cannot measure the FRC. So what's the FRC? That's this volume right here. It's the volume left inside your lungs after a normal quiet breath. The spirometry can't measure that because it includes the residual volume, which is that unknown. The only way to measure residual volume is to do a complex experiment that's not normally done on patients, where you measure how much a gas gets diluted when they inhale it, or there are a couple of other ways to do this. But they're all very complicated, and they're all usually only done in experimental settings or sometimes on lab animals. In our patients day to day who we're monitoring for lung disease, we almost never know the residual volume, and therefore we almost never know the functional residual capacity. So having said that, you're sometimes shown spirograms with volumes in tests, especially in your board exams, and this is the kind of data you would get if you went to the trouble to measure the residual volume in a patient. And in this case, the spirogram is upside down, so it starts at a high volume, like maybe 6 liters, and as the patient blows out, the volume starts to fall. But the same principles apply. If you want to know the FEV1, you look at the volume at 1 second, which is right here, and the difference between where you started and where you are at 1 second is the FEV1. The difference between where you started and where you end up, the lowest volume that you get to, is going to be the FVC. And you can calculate the ratio of FEV1 to FVC here, just like we did on the other spirogram. So just like with the regular spirograms we use in clinical practice, these spirograms with volumes have different patterns for obstructive and restrictive disease. So once again, let's look at a normal patient in blue here. If a patient has obstructive disease, the volume goes up from normal. Why does that happen? Well, it's because there's air trapping. There's an obstruction to getting air out of the lungs, so the volume goes up. This makes it very easy to recognize the curve. Just look at the starting point. Here's the normal starting point. The obstructive patient is starting at a higher point. It must be obstructive disease. Restrictive disease, on the other hand, starts from a lower point. The lungs are restricted and the patient cannot draw in enough air. Therefore, the volume where they start when they do their spirogram is lower compared to normal. So these spirograms with volumes are much easier to pick out obstructive versus restrictive than the others because you know the starting point. If you don't want to rely on the starting point, you can still follow the rules I laid out before. The restrictive curve has a similar shape to normal because the lung mechanics are the same. It's just that you can't get enough air in. On the other hand, the obstructive curve has a much slower, gentler slope, and that's because there's an obstruction to air getting out, so it can't move out of the lungs as rapidly. Now what you'll see pulmonologists do in clinical practice is generate something called a flow volume loop from the spirogram data. And what they're going to do with the spirogram data is plot the volume of air that's blown out on the x-axis and the flow rate at which air goes out on the y-axis. And you'll get a curve that looks like this green curve right here. So the total amount of volume that gets pushed out by the patient is right here, and that's still the FVC just like before. It's harder to get an FEV1 off this curve, but you do get a very useful measurement right here called the PEF, or the peak expiratory flow. And this is something that's very useful to follow in patients with asthma and other types of obstructive lung disease. The PEF is going to fall when the obstruction gets worse. And you can add the inspiratory flow rates to this curve, and then you generate a loop. That's why it's called a flow volume loop. And this green line goes around in a loop showing you how fast air is moving and what kind of volumes are going in and out of the lung. And different disease states have different shapes to their flow volume loop. So let's take a look at some flow volume loops in disease states. So here's a normal curve right here at the top, and let's look at the obstructive curve first. So what's going on there? Well, the first thing you notice is that the peak expiratory flow rate is much lower in the obstructive curve than normal. Normal is up at the top here and it goes all the way down to here in obstruction, and that should make sense to you. There's an obstruction to air getting out of the lungs, therefore the peak expiratory flow rate is much lower. In addition, notice that the normal curve has this rapid downslope here, whereas in obstructive it's got this gentle gradual slope here. And again, that's because of the obstruction. It changes the shape of the downslope of the pulmonary function testing flow volume loop. Restrictive disease, on the other hand, looks a lot like the shape of the normal curve, it's just smaller. There's a slightly less peak expiratory flow, and notice that the total volume that goes out of the lungs is much lower in restrictive disease compared to normal. Just look at the shapes of the curve. That's the easiest way to identify these. A restrictive patient will look very similar to normal. An obstructive patient has a very different shape to their curve on a flow volume loop. So finally, the last thing I want to discuss in this module is the work of breathing, and that's the amount of energy that the body has to expend in order to move air in and out of the lungs. And the amount of energy the body has to expend is proportional to the resistance of ventilating the lungs. That should be obvious to you. More resistance to ventilate the lungs, more work the body has to do to overcome that resistance. So it turns out that there are two forms of resistance the body has to overcome to ventilate the lungs. The first one is called airflow resistance, and like the name implies, this is the resistance to moving air through the tubes in the lungs. And it turns out that the slower you breathe, the less resistance there is to airflow. And why is that the case? Well, when you breathe rapidly, you create turbulent flow of air, and that has a lot of resistance and requires a lot of work to move it along. When you breathe more slowly, air moves in a nice laminar fashion, and it's easy to get it in and out of the lungs. So down here at the bottom, I've drawn a graph of breaths per minute, which is basically the flow rate of air. And here on the y-axis, I've drawn the work of breathing, which is proportional to resistance. So as you take more breaths per minute, the resistance to flow goes up, and therefore the work of breathing goes up. And that's why the airflow resistance curve looks like this. And this curve could change, by the way, for example, if the patient developed bronchoconstriction in asthma. That might move the curve up so that it looks like this. On the other hand, if you administered a bronchodilator, the curve might move down and be somewhere like this. But it always follows that same shape of going upward and to the right so that the airflow resistance goes up when you breathe faster. Second form of resistance the body has to overcome is called elastic resistance, and the best way to understand this is with a picture. Let's take a bronchi here that's connected to a relatively deflated alveoli, and now let's suppose we draw in a breath of air and we create a fully inflated alveolus here. It's going to take a significant amount of work to go all the way from the relatively deflated phase to the completely inflated phase. Now let's take a second example where we start with a relatively inflated alveoli. It's not as deflated as in the first example. And we take in a breath and we create a fully inflated alveolus. It's going to take less work in this bottom example because we didn't start as deflated as in the first example. Well, up at the top is what happens when you have a low respiratory rate. When you have a very low respiratory rate, the alveoli completely deflate and then they have to completely inflate with each breath. When you have a high respiratory rate, like down here at the bottom, the alveoli start off with some air in them and you don't have to work as much to inflate them. That's sometimes confusing, but take a second to think about it. But patients who are breathing rapidly need to use less work to expand their alveoli because they don't get as deflated as when patients are breathing slowly. So if we look at this curve down here at the bottom, that's what I've shown. This is the work of breathing again on the y-axis and breaths per minute on the x-axis. And the elastic resistance has a curve that looks like this blue line here. As you breathe faster, there's less elastic resistance to overcome. As you breathe slower, there is more elastic resistance to overcome. So a patient breathing at a low rate would be here, lots of elastic resistance. A patient breathing at a high rate would be here, very little elastic resistance. So if you put all the curves together, you get something like what I've drawn on this slide here. So airflow resistance is shown by the purple line again. It slopes up and to the right because the faster you breathe, the more resistance to airflow there is, and therefore the more work of breathing is required. The elastic curve looks like this light blue line here, and the slower you breathe, the more work of breathing is required to overcome elastic resistance. And so the total curves combine into something like this dark blue curve here, and you'll notice that it's got a nadir right here, which is at about 15 to 20 breaths per minute, and that's where normal patients like to breathe because it minimizes the work for the body. If you were to breathe faster than that or slower than that, you would have to work harder. This is the happy medium between the elastic and airflow resistance curves. So just like with spirograms, there are different curves for the work of breathing in restrictive and obstructive lung disease. So let's take a look at that. So this is the normal patient in blue here, and let's look at the restrictive patient first, which is represented by this green curve here. So the first thing you'll notice is that at all respiratory rates, the restrictive curve has more work of breathing required. And that should make sense to you. Patients with restrictive lung disease have sick lungs. It's harder for them to breathe. They have to expend more energy to breathe. You'll also notice that the shape of the restrictive curve is basically the same as the shape as the normal curve. It's just higher up. And that means that patients with restrictive disease tend to breathe at the same respiratory rate as normal patients in that 15 to 20 range. They're working harder to breathe overall, but the rate at which they're breathing is unchanged from normal. Now let's look at the obstructive curve, which is this red one up here. It has a very different shape from normal, and the nadir is shifted over here to the left, and that's because there's significantly increased resistance to airflow. This means that patients with obstructive disease like to breathe down here at a much lower respiratory rate. They like to take very long, slow breaths to keep the flow from becoming turbulent as they exhale and to allow air to move out of their lungs. And so you will see in patients who have obstructive lung disease that they're often breathing slower with deep breaths. Their respiratory rate changes in order to minimize the work of breathing. And that concludes our module on pulmonary function tests.